Good evening to my colleagues in India. This is Philip Katz. I'm looking forward to joining you next week for what I hope will be an enjoyable discussion of a topic very, very important to those interested in esophageal disease. I'll give a lecture on refractory GERD, after which we will have a case discussion and an opportunity to answer your questions regarding this complex subject. I look forward to seeing you all next week. Be well.
Good evening, everybody. On behalf of the entire Alchem team, I extend a very warm welcome to all of you. Heartburn and reflux are two of the commonest symptoms anyone would have experienced at some point of time in their lives. As per recent data, prevalence of GERD in India is 19.9%, which is slightly more than the global prevalence. And up to 40% of the patients fail to respond to standard dose of PPIs. To take us through more on the management of difficult to treat GERD, it is my proud privilege to welcome moderator of this session, young and dynamic Dr. Saurabh Mukhewar sir. He is Adjunct Assistant Professor of Medicine, Department of Gastroenterology and Hepatology, Cornell University, New York Presbyterian Hospital, New York City. He is a consultant at the Midas Multispecialty Hospital, Nagpur. Over to you, sir.
Okay. Hi, thank you so much for having us, and thanks a lot for working with us to spread the word. We have today an illustrative faculty who will be discussing refractory GERD with us today. I thank everyone on behalf of the Midas Medical Foundation. So let me start with the introductions. We have as a speaker today, Dr. Philip Katz. Hi, Dr. Katz, welcome. So Dr. Katz and I have had a pleasure of working together at New York Presbyterian, where he is a professor of medicine and director of the GI Function Laboratories in the Division of Gastroenterology and Hepatology. He's a recognized international authority on esophageal diseases. His research interests include gastroesophageal reflux disease, including nocturnal recovery of gastric acid secretion during PPI therapy and esophageal pain perception. He served as an associate editor for the American Journal of Gastroenterology, has contributed to the publication of over 190 peer-reviewed papers. He's past president of the ACG, founding editor of the ACG Universe. He's awarded the Chase Stanley Cohen Award for Research Excellence during his time at Einstein Medical Center in Philadelphia, and several other awards. So thank you, Dr. Katz, for joining us today. We also have a very highly accomplished and highly experienced national faculty with us today. We start with Dr. Naresh Bhatt, who is Chief of GI and Liver Services at Aster CMI Hospital in Bangalore. He's chairman of the Indian NBI Group, as well as past president of the SGEI and ISG as well. We have Dr. Professor Shobna Bhatia, who's a consultant gastroenterologist, head division of neuromotility, Department of Gastroenterology at Sir H.N. Reliance Foundation Hospital. She's former professor and head of gastroenterology at St. G.S. Medical College at KEM Hospital. She was the former editor of Indian Journal of Gastroenterology and national coordinator for the Indian Society of Gastroenterology Task Force on gastroesophageal reflux. And I've read her papers in the Indian Journal of Gastroenterology and GERD and the most recent Indian guidelines as well. So we are thankful to have Dr. Bhatia with us today. And we also have Dr. Ajay Kumar. He's chairman and head of department at BLK Institute of Digestive and Liver Diseases in New Delhi. He's received several awards, including the BC Roy Award, International Service Award by ASGE, J. Mitra Olympus Award, Cisco Pentax Oration. He's been a president of ISG before. He's the eminent member of Central Council of Health and Welfare in the Government of India. So thank you, Dr. Ajay Kumar. And we also have my father, Dr. Shrikant Mukhevar here. I'll not do any formal introductions. He's been practicing for the last 40 years and he's seen, I don't know, lakhs of patients with GERD probably by now, and extensive experience and innumerable talks and vast experience and teaching us junior gastroenterologists as well as seeing patients. So thank you everyone for being here with us today. So I'll hand over the session to Dr. Philip Katz, who will be presenting on refractory GERD today. Thank you.
Well, good evening, everybody. For me, it is morning. Saurabh, I thank you for this very kind invitation. I must say that it is a very, very interesting experience to be able to join people so far away from where I'm actually sitting. And it has been interesting to me as things have evolved over this clearly unusual, if not horrible, year in all of our lives, how whenever there is a disaster that something comes out of it that we can take going forward. And while I hope someday to visit you live and enjoy the pleasures of your country and see it, because I haven't in my somewhat long life, to be able to share ideas and to talk about things that are important to us medically, and being able to do it over this kind of medium has been a major advance. Most importantly, as I get into the formal part of my talk, we certainly read about the difficult times that are going on relative to COVID in your country. And having lived through the New York experience and the intensity of last March, there is some empathy, not just sympathy. So hopefully it will pass sooner than everybody thinks it will, and that you will have an opportunity to return to some semblance of normalcy. Although I must say it is interesting to see who's continuing to wear masks in the United States or not. And for those of you who are reacquainting yourself with Saurabh, I must tell you he is a talented young man. He was kind enough to help me out in a case in which I had an adverse event from a pneumatic dilatation, and he was quite adept at keeping my patient from needing to be admitted and having trouble. So Saurabh, I will never forget that, and
Thank you.
I look forward to our next time together. So I'm going to talk to you about refractory GERD, and I'm going to talk to you that in the context of my view of this so-called syndrome and clinical presentation. Now, you know, reflux is a disease that's defined by consensus, and many people use the Montreal definition. I will be very honest, I don't particularly care for it. So I've attempted to change it in the next iteration of the ACG guidelines. So we'll see how that goes with reviewers. But regardless, it is a disease with multiple symptom presentations. And the comment about heartburn and its prevalence is instructive, but reflux is a multifactorial disease. The genesis of symptoms is multifactorial. It's not universal that we can relieve symptoms, in fact, with anything we do, and it's hard to predict with any kind of certainty, regardless of the intervention. So the reasons for refractory symptoms are multifactorial. They vary from case to case. And as all of you as clinicians practice medicine, you think about every patient differently, even if you have an algorithm or a paradigm that you use to take care of patients. Now, refractory GERD is really a synonym, or is also known as the PPIs not controlling symptoms, because realistically, there are two scenarios in my practice. One is that GERD has been objectively documented by the presence of erosive esophagitis or an abnormal prolonged pH monitoring study, but the patient still has symptoms despite being on medical therapy. Because the reality is very few people go directly to an endoscopic procedure or to a laparoscopic surgical procedure. They get medicine first. The more common scenario in my practice and in the United States is that a patient has symptoms suspected due to GERD. They've been treated empirically, but the symptoms have not been relieved to their satisfaction. Excuse me, and they present to a gastroenterologist or a foregut specialist with so-called refractory GERD. Now, which scenario dominates is in part dependent on your practice. In mine, it is probably still weighted towards the patient who's never had a workup, but I must say I'm seeing more and more people who have objective documentation of GERD and remain symptomatic. Now, everybody then, as a provider, if we can use that term, which I hate, but it does seem to be common, is answering the following question. Are the residual symptoms due to GERD? And if so, why? Because that's how you develop a treatment plan for the patient. Now,
sorry, Dr. Katz, I apologize.
Yes.
Are you showing your slides? We can't see them.
I'm moving them. I apologize, but
Okay.
I guess maybe you can't see them. So why don't we switch? I'm looking at them and they're moving.
Okay.
Can you not see my screen?
No. So.
All right. Do you want to put up my slides?
I can do that. Give me a second. So.
And I'll switch to a, because I'm moving the slides and I see them and I thought we had everything shown, but.
I think, yeah, we changed it for a brief moment, but it's fine. We can do it this way. So here we go. So
Well,
maybe you can switch on, you can do a screen sharing on his own screen.
Okay.
I did, but let me see if I can do
That's
it.
fine.
I've lost my mouse.
I can move the slides. Can everybody see the slides? Just to.
Yeah, let me try and share my screen
Also,
again. And
okay.
you see my screen now?
Yeah, we do see a screen now.
All right. Then what I'm going to do is I'm going to start over.
Okay.
Okay.
Great. There we go.
How about if we do that?
Yes.
Is that okay with everybody?
Yep.
Yeah.
You'll hear everything twice. And I'm glad that you spoke up because I would have been more than halfway done. All right. My apologies for the technical issues. And maybe that's why we should always be live. All right. So let's see. All right. Do you see that slide move?
Yeah.
Yes.
Okay. So you have to see this slide because that was an important part of my introduction for year one. A remark on Thomas Paine's quote here that anyway put us in view. So, all right. So to start over, most of you all know that GERD is defined by consensus. Multiple symptom presentations. You heard me comment on the Montreal definition. I won't do it again. This is a multifactorial disease. The relief of symptoms is never universal. You can't predict it with certainty, regardless of the intervention. And the reason for refractory symptoms may be multifactorial and vary from case to case. I look at reflux that is called refractory in two scenarios. Scenario one, GERD's been objectively documented by the presence of erosive esophagitis, in this case, grade B, C, or D, an abnormal pH monitoring study, but you still have symptoms, either heartburn, regurgitation, or even your extraesophageal symptom. Scenario two, you have a patient who has symptoms suspected due to GERD, who's been treated empirically, but the symptoms have not been relieved to their satisfaction. In this case, the patient has never had a workup. Now, which scenario dominates is in part dependent on your practice. My practice is probably, still 60-40. Each of you will come about this in a different way. So the question that has to be answered in both scenarios is always the same. Are the residual symptoms that the patient has complained about, and in fact, they're often multiple, is it due to reflux disease? And if so, why? Okay, so this is where we kind of lost, or somebody made me realize that I was moving my slides, but you couldn't see them. Now, I like to frame this talk in terms of what has changed in the approach to refractory GERD since the ACG guidelines published in 2013, which is frighteningly 8 years ago, which means we wrote them in 2012. The PPI adverse event world has definitely exploded. Whether you believe in these events or whether you think they're real or not, they've certainly mandated that we look differently at how we prescribe medicine. We now have level 1 evidence for the efficacy of Nissen fundoplication in refractory GERD. We have level 1 evidence for magnetic sphincter augmentation, i.e. LINX, and the success of TIF. I won't comment on the endoscopic procedure that you all have recently described as a new addition to our armamentarium because it's not widely available in the U.S. and we'll deal with that perhaps in the Q&A. We have outcomes data on the effect of optimizing PPI. That is, way we say to do it, does it work? And we have a greater understanding of the reasons for incomplete response to medical therapy, which has truly resulted in a shift towards increased utilization of objective diagnostic testing. So anyone who leaves my talk should leave with the idea that you have to work the patient up. When they come to you with still having symptoms, you don't just change the therapy, you figure out why, and you do what you do. Now, I frame this talk to be about alternative interventions to PPIs, and I'll come back to medical therapy. But the transoral fundoplication, which again is being developed in many places beyond the traditional TIF, is an intervention for which I believe we need to set expectations if it's going to be done as a primary procedure. Now, the modern TIF procedure in the United States has shifted. It shifted from TIF 1 to TIF 2. That's important for people to think about when they review the literature, because the older literature was done with an inferior technology. At this point, the number of fasteners has increased to where the application is now standardized, although each operator has an opportunity to adapt to the patient and to their own intervention technique. But the number of fasteners, placement of the fasteners, and the whole technique since its introduction 10 years ago has made for a better procedure, and one that in the hands of an experienced operator actually works in the appropriately selected patient. And the extension of John Hunter and colleagues' studies published in Gastroenterology 6 years ago is instructive to people considering doing this procedure or any endoscopic procedure and selecting patients for that. So patients had incomplete relief on a PPI, and troublesome regurgitation was the primary endpoint. Developed probably by consensus, but one of the lead investigators, Peter Carrillis, was helpful in designing this trial. They all had endoscopy. They all had high-resolution manometry. So they all had normal motility, a piece of data that we often ignore when we pick patients for endoscopic procedures. They had an abnormal pH study to sort of quote-unquote prove that they had abnormal acid exposure. And they had to have an axial hiatal hernia less than 2 centimeters. They had to be less than grade C by the LA criteria, and they had to have a normal HRM. They were randomized to TIF versus a sham, and they all got PPIs for 2 weeks after their TIF or their sham. And it was a randomization of TIF and placebo versus sham and PPI only once daily. So for 12 weeks, patients got a proton pump inhibitor once a day. You could increase it to 2 BID for incomplete responders. And then the final evaluation was only at 6 months. So level 1 evidence only at 6 months. Important and instructive. Now, the slide here, I'm going to focus you, if you can see the pointer. They looked at regurgitation scores, they looked at heartburn scores, and they looked at combined scores. And they compared TIF placebo to sham. So as you move down the left-hand column and just simply look at the red line, the global improvement was quite statistically significant and was not necessarily compared to sham. So the sham group did a little better, actually, because of the PPI, but the TIF placebo group did better. Now, they also looked at pH control. And again, this is instructive and brings up 2 important points. Number one, you don't have to normalize your pH to improve symptoms. And that our improvement in or efficacy of procedures is not always related to pH improvement. So here again, the placebo group, the TIF placebo group overall showed improvement, but you notice that it doesn't necessarily normalize. Many did, but several did not. In the sham PPI group, not an improvement in pH. That would be expected to some degree. But again, the point here is that TIF is superior to even double dose PPI, probably for pH control, but it's marginal. Now, there is a little bit of follow-up data. This is a 5-year follow-up study published in 2018. Reasonable numbers, 60 at 1 year, 52 at 3, and 44 at 5 years. And if they looked at elimination of troublesome regurgitation, the results appear to be sustained, remembering that there are dropouts or people who have not yet been followed for 5 years. An observational study, not level 1 evidence. Now, again, if you look at pH control and you meta-analyze, always subject to the difficulty of meta-analysis, pH is improved overall, but it's not normalized. And as you compare to fundoplication and hiatal hernia repair, where pH is normalized, there is a clear difference, even though there is global improvement, as evidenced by this meta-analysis diamond on the slide. And then the little 10-year follow-up. Again, these studies are always interesting to me how people accumulate these data. I've done these studies, and scientifically they're quite flawed, but they are interesting. So if we look at 10 years, and we look at this slide, we look at people who are not on PPI, 1 out of 3. 40% have their PPI, which means they reduce the dose. 6.7% were on full dose PPI, and then some went on to have a fundoplication. And then a small number had complications, and that's not really totally discerned in the study. But only 15 patients had been followed for 10 years. So either this is pretty good, only 13% went on to have surgery, or you can say that the procedure doesn't last. Like many things, you can look at things two ways. I would say these are actually pretty nice data because I don't promise people that it's going to last forever. And since TIF can be followed up by an advanced procedure or redone, I don't think that's necessarily bad. Now, the magnetic sphincter augmentation procedure, or LINX, primarily studied for refractory regurgitation. And that's where people need to look at the data and then extrapolate. And the best data come from Reggie Bell and colleagues, a randomized trial of patients refractory to PPI daily. They had abnormal pH off their medication. They again had normal high-resolution manometry. They were randomized to a magnetic sphincter augmentation versus proton pump inhibitor BID in a 2-to-1 randomized fashion. They were followed up first at 6 months. And you see here in the magnetic sphincter augmentation group that close to 80% reported no regurgitation compared to the PPI group, who basically were unchanged. Now, this should surprise no one, since regurgitation is not necessarily an acidic-related symptom, but nevertheless, if you're looking at regurgitation as the primary symptom, MSA is clearly superior to double-dose PPI. If one looks at this in another way, relief from regurgitation on the far left, in the middle, GERD HRQL, and then the ability to discontinue PPIs, there's a clear advantage for the LINX device. And since it's the only device, I did not change the slide. But if you look at it, it's pretty substantial in terms of symptom improvement. Maybe too good to be true, but nevertheless instructive. And then in the small number of people who actually went on to get their pH study at the end of the trial, again, normalization of reflux episodes should surprise no one. The surgical intervention was better than PPI. The Demeester score similar. And those who normalized were actually what I would expect. So on BID PPI in my practice, about 70%, actually 85% will normalize their pH. And I expect the surgeons to do better. And this is consistent with what I see. So MSA, a good operation. Now, still recently in our world, but getting older as we go, is the randomized Veterans Administration trials published by Stu Speckler and colleagues in the New England Journal, looking at the role of surgery for refractory heartburn. Now, this is a complicated study that took a long time to do, but I will remind you of a couple of things. This has got 1 year of follow-up, and there was a very complex algorithm as to how you ultimately got to have your operation. So you had to be screened, you had to have a verified HRQL with bothersome heartburn, then you had to go on a 2-week trial of a PPI, omeprazole twice daily, and have persistent heartburn. So you got excluded here if you did well. Then you had a whole lot of tests, and you had to be deemed acceptable for surgery. and then have an abnormal pH monitoring study with impedance, showing that you still had residual disease and you had to have a normal manometry. So if you dissect this study, there should be very few people in your practice who get to this level. But when you do, you randomize them to surgery, to active medical therapy, or control medical treatment, meaning placebo, baclofen, or desipramine. You can see the complexity of the trial. 366 patients were enrolled. Ultimately, 78% of those 366 had PPI refractory heartburn and were randomized. I will show you here, 42 out of the 366 had PPI responsive GERD despite presenting with refractory heartburn to PPIs. So when you optimize and have people take PPIs the way they're supposed to be taken, patients still, some of them get better. A handful, not an inconsequential minority, about 11% had EOE, other abnormalities, and then a small number, but remember, clinically excluded, had manometric abnormalities, and one or two of them were actually achalasia. And then a whole bunch had functional heartburn, meaning that their MII pH monitoring was normal. They did not have residual disease. At 1 year, the surgeons did well. 67% improved their HRQL, but not everybody. And that was better than continued active medical treatment or control. Now, the major conclusion of this study is that surgery is better than medical therapy as we currently know it for people who have refractory GERD. That is proven by continued reflux on BID PPI. It's a highly selected group, and as you see, they did not get 100% who met the defined endpoint. A very, very complex group of people, and one that need to be worked up. I call your attention to this laparoscopic Nissen fundoplication versus meta-analysis published in Gastroenterology by Dr. Richter and colleagues almost 3 years ago now, comparing pH, lower esophageal sphincter pressure, HRQL, and persistent esophagitis, comparing 7 TIF studies to the world of laparoscopic Nissen fundoplication. And it's interesting that the HRQL actually served better with TIF. They felt that that was an aberrant relationship, probably because of too few studies. But it kind of was instructive for me that although the Nissen clearly does better for pH, it's not so clear that patients feel better just because they've had surgery. Complicated group of people that we will discuss, I'm sure, together. Now, this is a randomized trial looking at optimizing omeprazole dosing and symptom control, kind of extending Stu Speckler's observations or doing it before. They looked at 64 patients with continued heartburn on BID omeprazole who were not taking it optimally by history. They were randomized to optimal dosing or continued what they were doing. And after 8 weeks, there was a significant decrease in frequency, severity of symptoms on the optimal regimen. This was published in Digestive Disease and Sciences in January of 2019, if you want to look for the paper. But it does have a little bit of real data showing that optimizing PPI dosing relative to meals actually improves clinical outcomes as well as pH, as we showed 20 years ago. Again, I call your attention to this 42 patient out of the original 366 who had PPI responsive GERD with a 2-week optimized trial. Very easy to do in the office, not easy for patients. But I basically scream and yell at them and tell them if they don't want to have a tube in their nose, they should take their PPI the right way. Now, why is GERD refractory to medical therapy? Meaning, what does determine symptoms? Number one, it's the refluxate. It's principally acid, but there are people who have weakly acidic reflux and perhaps some who have bile. There's a difference in symptom production. Some people only have postprandial reflux, some only upright. I just put a Bravo in one of my nurses, and almost all of her reflux is at night. So those people need to be managed differently. Some people have grade C and D, some people have only grade A, and some people have normal endoscopies. Whether that's truly GERD depends to me on a pH monitor. And then again, all of these other issues, and we can't ignore the hiatal hernia, particularly as we advance into more or revisit endoscopic procedures. The LES anatomy is going to become more important. And I think failure of interventions is likely related to gastric factors as much as it is GERD, and we need a better technology than a nuclear medicine study to deal there. Very little issue with salivary production if you don't have Sjogren's. Esophageal sensitivity, very hard to measure, but as you know, this is a very big problem in trying to dissect patient symptoms. And if you have migraine headaches, irritable bowel syndrome, fibromyalgia, or other functional diseases, your heartburn's going to get worse. That's just a clinical reality, and you have to factor that into your decision making. So ultimately, an abnormality or alteration in any of those features could be responsible for the failure of therapy, or GERD may not be the cause of residual symptoms, or the residual symptoms are functional and not GERD. So ultimately, you got to work up the patient. And I'm not going to go through this slide in detail, but Prakash Gaiwali and consensus colleagues in the Lyon consensus, now a very, very popular thing for people to refer to, developed this consensus diagnostic algorithm looking at conclusive evidence for pathologic reflux here next to the arrow, borderline or inconclusive evidence. You got to have supportive evidence, and then against pathologic reflux. Now, I think that there are two features of this slide that I would like to call everyone's attention to. The top one is if you have an abnormal esophageal acid exposure greater than 6%, which is probably a demister of about 25 or 20, and you have long segment Barrett's, a peptic stricture, or LA grade C and D, you have GERD. And if on a 4-day Bravo, you have acid exposure less than 4% on 3 or 4 days, you don't have GERD. Everybody else kind of falls in the middle and actually requires that we think or do adjunctive testing. Now, I'm going to close by talking about why proton pump inhibitors may not control gastric acidity and revisit what really happens in clinical practice in real life. People do not take the PPI optimally. It doesn't mean it doesn't work. You can take it any time of day, and if it makes you feel better, I never change it. But the food timing really does matter in a handful of people. The dose may be insufficient. Now, BID PPI taken before breakfast and before dinner likely will normalize or take care of optimizing PPI effect in about 92 to 93% of patients. But there's an occasional patient who will respond to more than that. I don't usually give it. They usually go on to have a mechanical procedure. But it's not the end of the day to give that. Now, genetic variability in PPI metabolism gets a lot of writing press, but has never really moved to where we actually test in clinical practice. I'm not really sure what to do about this. You know, you could put everybody on rabeprazole, perhaps use pantoprazole to try and minimize genetic variability, but I've never figured out that that actually really helps. People who are H. pylori negative do not control pH quite as well on a PPI. Depending upon where you live in the world, what your population is like, you can guess what the percentage of H. pylori negative people are. This doesn't come into play in practice very often in the United States, but should make a difference. I tell you, I have a practice that is quite replete with people from the Orthodox Jewish community in New York. And surprisingly, the H. pylori positivity rate is quite high. I see a whole lot of reflux that's not responsive to once-a-day PPI in that group. It's very rare to see hypersecretion. The next time you see one, please tell me, because I'd like to teach people about Zollinger-Ellison syndrome. It's written about, but we rarely see it. Remember that PPIs once daily do not abolish acid secretion. That's why PPI adverse events are actually relatively rare. When Nexium or esomeprazole only controls intragastric pH for 14 hours, it's actually hard to believe that that would really make people sick. Nevertheless, it's important to realize, both when thinking about side effects and lack of efficacy. We've talked about dose timing. It matters. If you take your PPI before a meal and you actually eat, your pH control will be better than if you wait till lunch to take after your first PPI. And the time of day does make a difference. You take your PPI before breakfast, you're going to have more overnight loss of pH control. You take it before dinner, you do better. And if you split the dose before breakfast and dinner, that will give you the best intragastric pH control over 24 hours, and particularly in the late night period. And then finally, it appears that there is a potential plateau. I published this almost 14 years ago now, believe it or not, looking at a controlled observational trial comparing pH control with healing of esophagitis in 104 patients, showing a relationship between healing and intragastric pH control until you got into about the 16-hour range. After that, the curve appears to flatten. So it may not be necessary to bump the PPI dose to BID to heal, but remember, there's not a relationship between symptom control and pH, and the relationship of PPI response depends upon the symptom and the degree of esophagitis. You can heal much better than placebo. You can relieve heartburn much better than placebo if you have esophagitis, but it's not nearly as good if you have a normal endoscopy. Regurgitation, the advantage for PPI over placebo, decreases. For chest pain, it's very good if you actually have GERD. If you have a negative pH study, it's useless. And there's never been a good study to show that extraesophageal symptoms are improved over placebo. A complex disease with complex presentations. And then finally, PPIs do not reduce postprandial reflux episodes. Did I leave you? Can you still hear me?
Yeah, we can hear you. Briefly, the Zoom thing popped up, but it's fine now.
Okay, good. All right. So PPIs may not reduce postprandial reflux episodes. This is a study we did 20 years ago looking at reflux episodes on PPI in the first 2 hours after a provocative meal, with the patient lying on their right side and an impedance pH probe in place. Okay? So what you see is that on a PPI, you'll reduce acid reflux, but not total reflux episodes. So you still reflux on a PPI. It's not noxious, but that's why you probably can get regurgitation. Looks like I am frozen.
Yeah, I think you can go back to your PowerPoint window and then share full screen again, I guess. At the bottom right, the PowerPoint, yeah. Right, and I think now you can click through it. Yeah.
Now, we also showed that non-acid reflux causes symptoms. Okay, what we looked at was heartburn, acid taste, and regurgitation. Okay, we looked at acid and non-acid. This is before people started to talk about weakly acidic. Okay, so heartburn, you saw it with both non-acid and acid, more common with acid. Acid taste, regurgitation, and any symptom, again, more common with acid, but you could get it with both. So keep that in mind as you deal with this. And then finally, some people just don't have GERD, okay? It just works out that way. A whole bunch of people might have functional heartburn, okay? And that is negative esophageal acid exposure, negative SAP, maybe a normal pH study. So ultimately, and I apologize for needing to do part of my talk twice, medically refractory GERD is due to abnormal reflux control, a mechanical or motility issue, which can objectively be documented, or perhaps the symptoms are not due to GERD. If you think about that, you can develop a management algorithm of symptoms suspected due to GERD. And Saurabh, this is not published yet, but I put it in here since you're going to record this lecture. You can use this algorithm any way you want, but I'm not going to go through it with people looking here at this slide because it'll take too long, and that's not the way to go through it. But it divides people into previously empirically treated PPI without an objective workup, or people with previously objectively defined GERD, which is defined on the right side of the algorithm. So this is the way I would approach refractory GERD, and I've called it symptoms suspected due to GERD. I invite you to use this however you like, and hopefully it will help you all in your practice. So I hope, ladies and gentlemen, that I have been able to review some concepts related to refractory GERD. I have presented clear information related to mechanical interventions and reflux disease as we now know it. At this point, I've clicked off the slides. I'm going to throw it back to you. I believe we have ample time for cases and questions in the time we've divided. Thank you all for listening, and I appreciate you having me. A real privilege. Saurabh, back to you.
Right. Thank you so much. No, that was wonderful and pretty much in time. So, well, that's great. Thank you. And we look forward to the ACG guidelines with the new algorithm. So thank you. I believe there are a few questions, and I guess what we could do is go through the case, and it'll address, I suppose, a lot of questions that people may have. I'll request Dr. Atul Gawande, who is a gastroenterologist with us at Midas, to share the screen. And we'll just go through the case and have everyone's opinions. So it'll be nice.
Thank you, sir.
Atul, you can start with the first slide.
Okay.
Oh, okay.
Are my slides visible?
Yes, we can see it. Thank you.
So let's discuss with the case. A 33-year-old female who came with history of burning in chest and regurgitation since 3 months, which was increased after spicy and fatty food, and sometimes severe, unable to sleep. She was anxious, the symptoms affecting her work. She was worried about cardiac problems, and there were no alarm symptoms. On the history, she has a stressful job. She used to take 2 to 3 cups of coffee per day with no addiction of tea, alcohol, or smoking. On clinical examination, her vitals were stable. The BMI was 32 with central obesity. No skin changes to suggest scleroderma. Other examinations were within normal limit and ECG was normal. So,
Okay,
yes.
great. Thank you, Atul. So let's look at the next step. Now, let's click next, Atul.
Yes.
So what I'll request all the chairpersons to chip in. What would you do next? Would you try PPIs or perform any sort of diagnostic tests at this point? It's only been, yeah. Okay.
You're asking me?
Well, I'm throwing the question out to everyone. What would you do? Yeah.
Can I go back to just hearing the history just one more time, please?
Sure.
Sure. So, 33-year-old female. She came with burning in chest and regurgitation since 2 months.
Okay. I got it. So this is a young woman. She has one typical symptom, regurgitation. The burning could be construed as heartburn. One might put this under the category of typical symptoms, in which an empiric PPI trial would be reasonable, given the short-term intervention, the lack of dysphagia, and or warning signs. I would not directly tell her that this is not cardiac. That in my practice is always done by someone else, even in a 33-year-old. I wish that wasn't the case, but that's kind of the way things have evolved, as any of you who have interacted with our legal system in the United States. I would talk a little bit about diet, but not necessarily from the standpoint of coffee and stress. But I would not hesitate to work the patient up from the get-go. But most guidelines would put this under the realm of a PPI trial being reasonable.
Okay. Dr. Bhatt, what do you think?
I think I'd agree with Dr. Katz on a PPI trial, a fair thing. I think I would do once a dose. This lady has got a lot of problems at night, so one would consider using a dose at night, whether it's just a single dose of PPI at night, or whether you want to split the PPI to twice a day is an option. But focus, she's got a high BMI. That's, I think one would try and address that as well.
Okay.
Of course, there is a background of anxiety, whether it is primary or secondary, is something that I would keep in mind, because anxiety does play a role, whether, sort of worsening symptoms, whether it worsens reflux is a different issue, but it certainly worsens symptoms.
Right. Okay. Atul, you can ask the next click. So, any role of lifestyle modifications? Dr. Bhatia?
So, in the lifestyle, so the first thing she said is that she had a symptom increase with fatty food and oily food and spicy food. Now, Indians don't like their food to be non-spicy. But however, since she said that her symptoms were because of these, we could tell her to have a bland diet and see if her symptoms improved after starting the PPI. I would tell her to decrease the fat in her diet because extremely fatty foods are known to delay gastric emptying and increase the symptoms, especially since she does have an element of regurgitation. Though these lifestyle modifications have been suggested as being advise to most of the patients, data on these improving symptoms individually are not there. So it's always in line to start the PPI and also advise the patient to have lifestyle modifications. Of course, once the weight comes down, the amount of GERD might decrease, but that's not really been proved too much.
Right. Yeah, I think we always wonder when there's no the meta-analysis did not show any statistically significant difference with coffee intake. But as you know, this is like 2-3 cups, so we don't know if it makes a difference. So would you generally ask them to reduce it, or no, doesn't matter, just continue it as basic lifestyle, so it's fine?
So I like to ask the patients whether coffee worsens their symptoms. If they're getting worse symptoms with coffee, I tell them, please cut it down. If they're not getting worse, that's fine. I let them have it. Okay. Right. But I do tell them to decrease their intake of, say, mint or soda, where there has been recent evidence showing that aerated drinks do increase reflux. So there are some things that are there which, you ask the patient whether if these things increase their symptoms, tell them to cut it down. Right. Otherwise, let them have their normal diet, split the meals, have more frequent meals, small quantity meals, tell them not to lie down or bend 2 hours after a meal, because that, of course, we know increases the regurgitation symptoms. For bending down, I really tell them if somebody is found to have a hiatal hernia, it helps to tell them that even bending down will increase intra-abdominal pressure, and that would increase their reflux. But otherwise, individually, lifestyle modifications don't help.
Right. And
unless they're combined with the PPI, yeah.
Yeah. And in terms of diet, the other thing that I keep hearing is when I eat non-vegetarian food, things get worse. Now, I wonder if it's related to the way it's cooked in India versus, if they consume something that's boiled and non-fatty, non-spicy, which is not how most people have it. So I wonder if it's related anything, because there's some data to suggest that it worsens in Indian population. Doesn't apply to the West because a lot of people eat non-vegetarian food basically. So
yeah, I guess it's the way it's cooked in India, one. Secondly, as compared to vegetarian food, non-veg food does have more proteins, more fat, and it tends to have delayed gastric emptying as compared to vegetarian food. Right. If you keep the amount of fat equal. So that may be one reason why patients feel that this gives rise to more symptoms.
Okay. Yep.
But that's a personal opinion. I don't think there's any data on this.
Right.
Oh, so
can I have a comment?
Yeah, sure.
Yeah. I don't pay much importance to lifestyle modification in routine practicing treatment of these patients where they have a mild to moderate disease. But in case the patients are not responding to double dose PPI, probably then I would give importance to these lifestyle modification, because practically speaking, elevating the bed by 8 inches or the other parameters whichever have been elaborated are not very, easy to follow in practice. So unless and until it's mandatory, because majority of the patient would go better with PPI. So that's my practice.
Okay. All right. And we'll just move on to the data. Next slide.
Yes.
So, Saurabh, I think yes. Dr. Katz had a comment to make at this point.
Yeah. He's saying something.
Just very briefly, this is a complex area. It will never go away. Mm-hmm. There's science to support fat and carbohydrate and protein differences in LES pressure and gastric emptying as was measured. Whether that laboratory science translates into patients, as you all know, is a difficult issue. What I find most helpful in my thinking is to decide whether I'm trying to relieve symptoms or make a diagnosis.
Right. Okay.
Or both. But if I'm only trying to relieve symptoms, whatever works is fine. If the patient really has GERD, it becomes to me a little different. And then telling people what not to do because of GERD becomes different than coffee makes me burn, don't drink coffee. Orange juice makes me burn, don't drink coffee. When I eat meat, it makes me get heartburn, then don't eat meat. And I mean, I'm not trying to be funny here, but realistically, you can spend a lot of time doing this when the practical end of it is we don't know the answer. Anyway, so we can move on because I'm sure you have a lot of things in this case you want to talk about.
Yeah.
And go.
Okay, Atul, can you move on to the next slide?
Yeah.
So this is sort of where I suppose the trial of PPIs originates. A trial of short-term PPI versus objective diagnosis of GERD on EGD or pH-metry. Next. The sensitivity for this is 78%. So, and specificity
is only 50%.
54%. Yes. So basically, people who don't have GERD, 46% will get better with PPIs. So that's the problem. But I guess it's just convenient, and that's why we just go ahead and do it. All right, next. And then this recent data with lifestyle intervention and GERD, as alluded to by Dr. Bhatia, weight loss, level 1 evidence. There's some evidence to support early evening meal, dietary fibers, head of bed elevation, and for those who smoke, stopping smoking. But again, this is all mild, if any. PPIs do play a major role regardless. Okay, next.
So in this case, in view of typical presentation of GRD, she was advised tablet rabeprazole 20 milligram once a day, and she was advised for weight reduction. So on follow-up, 4 weeks later, there was 40 to 50% relief, but she continues to have symptoms. So next, what's next?
So now this patient is on once a day proton pump inhibitor, rabeprazole, and on 4 weeks, and she has persistent symptoms. I'd say partial relief of symptoms. Next. Okay. So few options here. Increase the dose to twice daily. That's high dose PPIs. Now perform upper GI endoscopy or switch to a different PPI. So let me ask Dr. Kumar, what do you think about increasing the dose to twice daily using high dose PPIs? I guess Dr. Katz did point out some benefit.
We are all aware that the empirical PPI trials have been with a double the dose, a significant number of them. And in fact, that's data of meta-analysis of 70% sensitivity and 50% specificity. A lot of data was pertaining to double the dose of PPI trial of about 8 weeks. Now, if you have to follow seriously, yes, that is there. But what I do in my day-to-day practice, actually, if there is a partial relief, I am personally not, I'm in a mental state that I like to dissuade from using higher dose of PPIs. Most of these patients, with passage of time, they will start improving. I will add an SOS anti-acid as demand and will reiterate lifestyle changes. I'll just go back to what was discussed elaborately and beautifully by Dr. Shobna regarding the lifestyle changes. I strongly believe that lifestyle changes should be enforced for a different reason. That I understand that the PPIs will take care of most of the symptoms, but then we are looking at a long-term disease, and if we have to get the patient out of a PPI in the longer term, then patient has to go back to the lifestyle changes. And this patient actually right in the beginning is talking about anxiety. So I will try to take care of that as well and try the lifestyle modifications in addition to the exercise and try to learn on how to relax, some meditation, other things will be helpful. So I will personally continue the same dose. Yeah, you will not differ too much if somebody tries to say, I will do the double the dose and try for another 4 weeks. As far as going for endoscopy, Saurabh, what happens is it's a fresh case. If it comes to a primary care physician or a second physician, which audience, a lot of audience will be from there, I will say continue for at least 8 weeks before you think of anything else. Normally, we have red flags to do an endoscopy, that when is to do endoscopy, and that is somewhere which we should not be missing. If the patient has anemia, patient has dysphagia, patient has loss of appetite, patient has loss of weight, or any history of bleeding of any nature, and that is the time when I will not withhold the endoscopy for a single second. But in a setting like this, if the patient comes to me to a tertiary care center, then yes, I will go for endoscopy. I'm trying to differentiate where this patient has presented in a primary care, secondary care, or a tertiary, because I practice in a tertiary care setup. Patient comes to us with a different mindset, expectations, and quite often trying certain different medicines prior to us. Over-the-counter medicines are used rampantly, and a lot of patients are using it. So I will go for that. I do switch to a different PPI very rarely. I don't think it matters. I think all the PPIs are the same as far as the effectiveness is concerned. Psychologically, when the patients have been taking for a long time, it's a different thing. But in this short term, I don't think it will make a difference. So I'm sharing my practice viewpoints that I will continue the same dose for another 4 weeks with an SOS antacids. I will not go for an endoscopy to begin with unless there are red fluids. And I don't think there is any fun of shifting to a different PPI. At the same time, I will not be differing strongly from anybody who says, go for the double the dose. At the same time, in a tertiary care center, if somebody says, do an endoscopy, fair enough. Now, you want me to answer the safety of PPIs, talk about that?
Yeah, we can go through it one by one. Well, I can ask the same thing to Dr. Bhatt as well. What would you do for twice daily?
I would not hesitate to switch to twice a day PPI. Maybe, especially as I said earlier, consider an evening dose, pre-dinner dose of PPI. I don't think if the patient has got significant symptoms, my patients don't seem to do much better with an H2 receptor antagonist or antacids on a regular basis. The question of doing an endoscopy, yes, again, individualize it if the patient is extremely anxious. We would fast track to an endoscopy, but strictly speaking, short history, I think we could wait. Switch to a different PPI, I think too early to really consider doing that.
Right. And now we have these delayed release formulations for once a day with sort of dual release, so that you have once a day formulation and getting twice daily equivalent sort of effect. Do you use any of that?
No experience. Okay. I prefer to use esomeprazole because of the kind of longer coverage of acid control. So our personal choice is that of esomeprazole for reflux disease. But I think it's fair to use any of the other PPIs as well. I have no experience with the double dose or the longer acting, formulation, delayed release or dual release, no experience.
Right. And just going back to the safety of PPIs, I guess that's a different debate in itself, and there's so many issues and unproven side effects. Maybe Dr. Bhatia, what is your feeling on the safety of PPIs?
You're muted.
Oh, okay.
She's muted.
Oh, okay. Dr. Katz, if we can share with you.
So I'll thank you, Dr. Katz, for pointing that out. But safety of PPIs, I guess in the 30 years that we've seen them, I haven't had too many complications of these. Right when omeprazole came in, we found that some patients did complain of loose stools, and we did a study and found that patients did have a change in bowel frequency and consistency. So probably some of them do have a mild diarrhea, but that's not really serious. And we know that from multiple meta-analysis, long-term studies, that the only serious side effect is enteric infection. All the other side effects have now been thought to be non-serious. There was some data to show that the odds ratio for renal disease was over 3. But I guess I have seen only one patient who developed a renal disease following a PPI. But that's about the only thing. I don't find any complications in the majority of the cases.
Okay.
So I guess that's what everybody's opinion would be. But we can take other opinions as well. Just a small thing about switching to a different PPI. And I agree with Dr. Naresh, but that we know that esomeprazole has a better acid control. You go back to David Graham's study about 2 years ago. Of course, that study pertained to H. pylori, but they found that when you compare the efficacy of other PPIs, 20 milligrams of omeprazole is equal to more than 30 milligrams, 20 milligrams of rabeprazole or pantoprazole, or esomeprazole is actually equal to more than 30 milligrams of omeprazole, whereas pantoprazole is the least effective in such cases. So from pantoprazole, you can actually up to esomeprazole if the patient isn't responding.
Okay. All right.
Yeah.
So moving forward, Atul, if you want to go ahead with the case. All right. So I guess we've gone through this. We can move forward. There's no difference in switching PPIs or basically increasing dose to twice a day in patients with persistent symptoms. Either you switch in this particular series to esomeprazole or increase to twice a day PPI dosing works equally well. I moving forward. Next.
So on EGD, the EGD was normal.
Okay. So we ended up doing EGD. Okay.
So, and so we asked the patient. So the drug compliance was good, and she was taking PPI.
Can I ask, was the endoscopy done on PPI or off?
So it was on PPI.
Right.
Okay. And with no disrespect to the word normal,
Yes, sir.
does that mean that the Hill grade valve was a grade 1 and that there was no hiatal hernia at all?
No, sir. The his grade was 1, and there was no erosions. Yeah, everything was normal.
Got it. Okay.
Yeah, I think we ideally would love to have these people off PPIs before the endoscopy. I think it's just practical challenges that we encounter, and people come from far away. So, point well taken. So, Atul,
No. I mean, the practice patterns are practice patterns, and
Right.
I think it's unfair to do anything but to tell people what your practice pattern is when you can only support it with limited data.
Yeah.
I like to do as many endoscopies off PPI as I can, because I'm going to put a Bravo in if it's normal, if they've been off a PPI. And I like to keep them off for 2 to 4 weeks, even though very few people will do it without screaming at my secretary. Because then I might get a little chance at actually seeing erosions in people who've been on a PPI for a long time.
Right.
So, you know, when you look at algorithms are meant for the purist. So I respect all of these difficulties in practicing medicine.
Right.
But the reality is, at some point in time, this young woman needs a diagnosis, and she doesn't have one yet.
Right.
Right now, we're treating her as if she has GERD.
Right.
And I'd venture to say she doesn't. and when that and when that's going to be arrived at, well, I don't necessarily think that I'm always right, but that's my perception of the case. So when that gets arrived at is, you know, there's no rush.
All right.
But ultimately, we're going to get there, because if that BID PPI works, she's going to ask when I can come off.
Right.
And you're all going to try, because that's the modern world.
Right.
Anyway, keep going.
Okay.
I mean, this is a perfect case, because this is as real life as it gets.
Okay, Atul.
Okay, so we asked her. So she was compliant to the drug. She was taking PPI 30 minutes before food. So we decided to increase the PPI dose to twice daily.
Okay.
So she has a follow-up 4 weeks later. She was better for initial 3 weeks, but symptoms recurred again.
Okay.
So over to you, Dr. Saurabh.
So, you know, I guess this would fit in the category of what we term as refractory GERD. She's maybe not 8 weeks of BD PPIs, but I guess it's enough enough
I have
amount of PPI that she's received.
I have a problem by calling it refractory GERD. We are accepting a diagnosis.
Actually labeling of
I think refractory symptoms.
Refractory symptoms would be the right term.
I think would be a better way to.
Agreed. So let's call it refractory symptoms that she has, despite a fair amount of PPIs. Let's put it this way. So, what could be the possible causes? I think we've alluded to that: non-erosive reflux disease, reflux hypersensitivity or functional heartburn, achalasia, eosinophilic esophagitis. I just like to ask, the panelists, how often do you see achalasia in your practice in such scenarios when people have been on BID PPIs? India is much more than the West, so
I don't think I can give you a number,
yes,
but I would say in a year we would pick up about 6 to 7 achalasias from this group of patients who come to us with heartburn.
Yeah.
Right. Okay. Yeah, I think it exists, but a small number, but I guess it exists if enough to
sort of talk about that how many of them get eosinophilic. Surprisingly, maybe we are underdiagnosing because under-suspecting. We don't see too much of eosinophilic esophagitis as compared to the Western data that we see day and night. I mean, I said the opinion of like...
we are seeing some eosinophilic, maybe 1 or 2 a month, definitely we are picking up. It's there, but you'll have to pick up from that population of patients who are atopic and things like that.
Right. I think we saw this probably much more in the West, but I think what the threshold to biopsy is much higher, I feel, in India, where we wait to see those rings, but we know very well that biopsies, that those features are not in line with eosinophilic esophagitis always. So, but I haven't really seen much in my experience as well. Yeah.
Actually, we've been, sorry.
Okay, so if you look at patients who have atopy, as Naresh just said, and if you carefully ask them, so ask them whether they have asthma, atopy, and any allergics to food, then patients come out and say that they have worse symptoms with certain food items. That's when you start thinking and maybe biopsy them. The blood tests don't really help because peripheral eosinophilia is not seen in many of these patients. Secondly, Saurabh, just a quick question to you. Is this patient had predominantly regurgitation, correct? Now, this regurgitation, if you go back and ask her, was it sour or non-sour? That's something we always miss. So quite a lot of patients keep saying regurgitation. They do not complain of dysphagia. They complain of this retrosternal burning. And that's when you start thinking that we probably do not have true reflux, but that regurgitation that's coming is actually from the esophagus itself.
Right.
So that's when we suspect achalasia.
Fair enough. No, the nocturnal regurgitation.
Rumination to this list of diagnoses that you've considered, I've read a lot, I've heard a lot, but I've tried it in manometry in at least 5 of the patients in the last year. Just no one turns out to have rumination. Have you seen it around? Yes, we do see. But I don't have access to a combined mano plus pH impedance. So I guess we can't prove it. But on clinical grounds, we do make a thing. But yes, it's there. I don't know to the number. Maybe Shobna can add to that, because I think she has access to more physiological testing than we have.
Yeah, I only a few. I don't have too many of those. So just a couple of them where we proved it, but no, not too many of those.
Yeah, I guess just bland regurgitation during food and...
So regarding the bland regurgitation, yes.
Right.
I have a patient who had 8 years of regurgitation and heartburn, and it's just on history that I told him that most likely this is going to be something else, and he turned out to have achalasia.
Ah, right. Okay. And I think my dad, he was probably commenting on eosinophilic esophagitis.
Yeah, sorry.
Yeah, actually, in fact, we've been suspecting these diagnoses and making the biopsies from the lower, middle, and upper esophagus as per the protocol. And we've been trying to search these patients for so many years. And we were surprised to get one in a year, having searched for them for quite a long time. So I feel that definitely the prevalence of, at least in center part of India, the prevalence of eosinophilic esophagitis is certainly not that common. And presentation as burning of achillea is certainly seen. We get alert when the patient with burning in retrosternum not getting better with PPI. One has to think in mind of diagnosis of achillea, and one has to rule out that.
All right. Okay. Well, thanks. So we can move forward with the case, I think. Atul?
So
Okay.
what is the next?
Yeah, few more questions, I guess, just to next role of adding baclofen. So we do have a lot of burping in India, I guess. So any comments by Dr. Kumar? Would you add baclofen? Do you use it?
Only if they have a persistent hiccup that associated with hiccup, then I will consider adding baclofen. But otherwise that, I think the common drugs which are being used in India very frequently, not necessarily rightly, is a prokinetic agents, and number of such are available in the Indian market. But baclofen I do use very rarely per se. I mean, I will, I'll keep it as a I will use it for a persistent hiccup, yes, but not routinely for a simple GERD.
I would use baclofen in those patients who have a difficult cough, because baclofen has been shown to cut that reflex, cough reflex. So I would use that. Rumination, those few patients that we have used baclofen with biofeedback with some success. But in the routine management of a patient like this, so I agree with Dr. Katz that I think we are away from GERD in this patient. So I think it's time to find out what she has rather than trying, empirical therapy with various pharmacological agents.
Fair enough. Dr. Katz, how's your experience with baclofen? Do you use it?
I don't use it much, to be honest. I have the opportunity to have just about every piece of technology that is available to make a diagnosis in these patients. So I tend to use very little empiric therapy without objective diagnoses. And perhaps that's a bias of being able to either do Bravo or impedance pH or manometry with impedance. Those are luxuries that I can afford. Yeah. So I just don't use baclofen. I don't use prokinetics. I don't use sucralfate unless there is objective reason to do so. Occasionally I'll do it in the scenarios that were mentioned, even in the absence of GERD, because I still have the patient. But, so, this patient would have had a 4-day Bravo pH a long time back, because I simply have access to the technology and the insurance company would reimburse for it. So we would do it and then we would go from there. I think that data as an empiric drug have not been forthcoming, and the short-term data when you have proven GERD is actually reasonably decent, but side effects really kind of preclude people being on it long term. So I rarely use it.
Okay. Next, topical agents. Any experience, comments, Dr. Kumar? Do you use?
Yes, I'm quite.
You could mention use antacids. So
I'm quite fond of using alginate in the patients who are not responding. But as I earlier discussed, in this particular patient, if the patient is not responding before adding anything, I will likely investigate further. But yes, if the patient of a known reflux is not responding, I'm used to, I love to use this, especially patients who have more of regurgitation. I do use alginate.
Okay. All right, next. Sorry for that. Okay. How about prokinetics? We have a lot of prokinetics in India, and they are very popular amongst general physicians for sure, as well as doctors. So, Dr. Bhatia, what's your feeling about prokinetics?
I do use them, but only when I think that bloat is one of the added symptoms, and in patients with sour regurgitation. So I try to keep it to only a PPI and maybe add an alginate initially if the patient has typical symptoms. But prokinetics, I'm not very fond of them, simply because there's a lot of data to show the side effects of prokinetics.
Right.
There's, first of all, just to add, that none of the prokinetics actually improve esophageal emptying. Right. None of them increase peristalsis. There was some data regarding metoclopramide improving the LES pressure, but that was only improving it by, say, 10 or 15%. So in somebody who had a LES, lower esophageal sphincter pressure of about, say, 10, then a 10% increase would make it to, say, 11. So it wasn't really significant in that way. Secondly, most of the prokinetics that are available, domperidone as well as levosulpride, they have side effects like galactorrhea and menstrual problems in women. Right. Levosulpride is also supposed kind of has some neurological side effects. Our neurologists are telling us a lot about it. So I'm not really fond of prokinetics by themselves. Okay, well, like I said, it's only when I suspect that the patient may have mild gastric delay or they have regurgitation as a primary symptom, that's volume reflux, will I go and add a prokinetic.
Right.
Saurabh, just to reiterate again, I almost never use prokinetics.
Yeah.
I think I'd like to reiterate for this audience,
right,
that's listening in, that prokinetics are virtually useless.
Right.
Maybe 1 in 1,000 patients may benefit, but I think by and large we're wasting a lot of money and creating new problems with patients by using prokinetics.
Right. Yeah.
Saurabh, I'd like to add to this. There are too many combinations of a PPI with a prokinetic available.
Yeah.
I'd like to share with the audience that till date I've never used even a single pill of a combination of this. Because if I have to use it as a very small percentage with who have a postprandial gastric fullness and all that, then I will use it separate from PPI. Otherwise, you're stuck to what patients keep on taking that combination for years together and with the unforeseen outcomes or adverse events.
Yeah, no, I think I believe I do feel that we see a lot of dyspepsia in combination with GERD. So I feel that in the short term it's reasonable, but then as you correctly pointed out, everyone seems to take them long term, and I mean we've seen some bad patients with neurological side effects, certainly galactorrhea a fair amount with these prokinetics. So certainly no role in such patients with GERD, but I suppose short course with dyspeptic symptoms are not unreasonable. Yeah. All right, next.
So another thing, sorry, Saurabh, for interrupting.
Yeah.
Just to tell you that many of these combinations have the full dose of the prokinetic. So, for example, if there is a PPI of, say, 40 milligrams, the domperidone would be 30 milligrams. Right. And sometimes patients take it twice a day, not knowing that the domperidone dose has been doubled in this. And that's when the side effects commonly occur. So that's what we've got to be careful.
Right. No, exactly. I think that people make mistakes oftentimes. Okay,
Yes.
Dr. Katz, thank you for being here. I know it's almost 7:30 now, but Dr. Katz has to leave. So thank you, Dr. Katz, for being around. If okay with all the chairpersons and panelists, we can continue with the case and then, answer a few questions if time permits. All of you.
Please do. I want to thank all of you. I must say this has been very enjoyable for me to listen to how you manage your patients in a combination of a practical and a data-based way. It does make me feel privileged on one hand and disappointed on the other that I probably lose my ability to think sometimes because I have all this technology. Anyway, I wish you well. I hope you all stay safe and that our paths will cross again. And I told Saurabh I'd be happy to come back and talk about achalasia. It would be fun.
Yes.
Love to have you here next time.
You all be well. I must go on to the rest of my regular workday. Enjoy. Thank you very much. Thank you, Saurabh. Bye-bye.
Thank you.
Bye. Bye.
Bye-bye. All right, Atul. Let's go on next. Bile acid binder. We just threw it in there because there's one data, I suppose, in the gastro paper, not out there in the market. So I guess we'll just move forward with this next. How about H2 blocker at bedtime? I guess it's part of the guidelines from the 2013 ACG. Any comments? Do you guys, after BD PPIs, there's some nocturnal symptoms, would you add H2 blocker or not really?
Yeah, sometimes we would. Instead of adding another dose of a PPI, sometimes we'd use H2 receptor antagonist for the so-called nocturnal breakthroughs, acid breakthroughs.
Right. Okay. All right. But for the most part, is that how frequently, say, just like less than 10%?
Yeah, very small number, very small.
Yeah. Okay.
Saurabh, sometimes I prefer not to go to a double dose PPI, but shift to a nocturnal H2 blocker. Give a single dose PPI and have a H2 blocker. And even when you're de-escalating from your PPIs, it's a good option to have an H2RA at bedtime, knowing that these will have intermittent, loss of their efficacy. Tachyphylaxis.
Yeah. Right. Okay. All right. Next, Atul. Okay. I guess we've gone through this. Manometry, how common is achalasia?
Yes.
Rarely there, but yeah, I've personally seen 5 or 6 myself. So I guess much more than in the West. The data I think is 1%, but probably more in India. Anyway, next, let's move forward, Atul. So yeah, well, I think let's move forward with this. So this patient did undergo manometry and this was normal. And next. So, okay, so we plan to do pH metry for this patient. I guess the question, on PPI or off PPI?
This is a no-brainer.
This is a no-brainer, absolutely.
On whatever diagnosis, it has to be off PPI.
Off PPI, okay.
Yes.
Yeah. So you want to get the diagnosis in line with that combination of tests?
Not only that, they should be off PPI for about 7 to 10 days.
Yes.
It's just that it's not that you stop it for just 1 or 2 days and you do it, then you will not get the results.
Right. No, fair enough. I think just, to play devil's advocate, sometimes I feel you can do it on PPIs to at least, if you see there's evidence of reflux, just because most likely I won't be able to do it twice for the patient, right? So I do it off PPIs and then say if it shows reflux, then the patient has twice a day PPIs not controlled, then I'll be stuck whether I have to do it now on PPIs to check if there's residual reflux or not. I think that's just sort of a practical challenge that you may encounter.
But that number is going to be small. See, if you have a patient who's got typical reflux symptoms and is responsive to PPI, see, irrespective whether there is documented reflux or not, you got to address the symptoms and continue medication. Right. So that so-called weakly acid reflux or functional heartburn who are responding to PPI, you got to continue doing that. Now the question comes if someone will not respond.
Yeah. Exactly.
In which case you have to stop, establish a diagnosis and decide what path you're going to take.
Right.
Correct.
Yeah. Actually, at this stage, it was in our mind that whether she really has reflux or not. So we decided to switch off the PPI for 15 days and then get her manometry. pH metry, sorry.
Yeah. Okay. Next, Atul.
So this was her pH metry. We stopped PPI for 14 days and then did a pH metry analysis. So her percentage time of pH less than 4 was 10.6, which is quite significant. Her Demister score was 41.7, which was quite high above normal, and symptom index was 50% at all the time. So yeah, so next to you.
Yeah, a bit of a problematic situation now. So
you have
In fact,
but
Saurabh,
non-response.
Saurabh, this the earlier slide should have been now. That
what?
I mean, after diagnosing, GERD, which is not responding to double dose PPI, all those medications should have been right now here. That whether you want to add baclofen, whether you want to add H2 blockers, or whether anyway, it has been discussed.
I think this patient is, I think he's got symptoms. I think I would consider some other, maybe a surgical option or some other endotherapy if it's feasible.
Correct.
Right. Next, CYP2C19 polymorphism. Now, if you are on twice daily PPIs and an established reflux, is that even available in India? I'm not sure. Any idea?
So we did a study on this, and we found that rabeprazole does have an influence on the, CYP2C19 does have an influence on the rabeprazole metabolism, but not on pantoprazole metabolism.
Okay.
So you can shift the PPI. The patient was only on rabeprazole.
Right.
So you can shift to another PPI and see whether she responds.
Yeah. I think in these particular cases, probably.
Yeah. A shift in PPI may be better. So you can try that. And maybe it will work, maybe we don't. But
yeah. Okay. And next, I guess.
No.
Very unlikely, obviously.
No, because this patient didn't have duodenal ulcers. There was no esophagitis. So if there was esophagitis.
I would disagree, Shobna. We've had patients with Zollinger-Ellison pure coming as refractory esophagitis. This patient didn't even have esophagitis.
Yes.
Yes, fine. I agree that may be a strong point too. But purely as reflux manifestations, we have seen Zollinger-Ellison.
Okay. Yeah, there's been some data to show that patients may not have your classic ulcers and they would actually just have refractory bad reflux. Of course, I guess not in this context. Agreed with all of you. Okay, next. So I think in this particular patient, we continued the twice daily PPIs because of her stress component and anxiety. I guess Atul, you can mention, we used amitriptyline just to add on to see if that is contributing to her symptoms and can improve. Basically, I think that next, I guess that ends our case there. Yeah, and what I'll do is I'll also take some questions from the audience. There have been a few questions around. Atul, next, sorry. Next, I have some questions from the audience. I'll just throw it out there for all of you to answer. Okay, I guess some of these things we've already answered. Long-term use of PPIs, will it cause constipation? I guess not.
Yes, it does. Constipation.
Have you seen it?
One of the things of PPI, may not be terrible, but yes, some patients who are sensitive do complain.
Okay. Next, how are GERD and chronic laryngitis related? Many times throat pain is the only symptom which often misguides. This is from Dr. Sandeep Kapadua. Yes.
Okay, I'll take this again. Yes, we've heard a lot about extraesophageal manifestations of reflux disease. And I think somewhere about 15, 20 years ago, we started talking a lot about this. But now the ball is being sort of slammed into our court because all ENT patients get referred to us for management of reflux. And I think that's an overdiagnosis. I think a very small number of patients actually have laryngeal manifestations. It is there, but it's a very small number. And the practice of universally treating all patients who, sort of points to his throat with double dose PPI, I think is perhaps not
slightly overkill.
Science.
And Naresh, it's very difficult to diagnose these patients because many of these patients would have a normal pH metry also.
Absolutely.
And the response to treatment is also very often, it's not good response, and they have to be given twice a day PPI for a long length of time, say 3 to 4 months. So as you rightly said, it is the I just rightly said that it is a double dose is, they have been overused. Yeah.
Right. Now, okay, another question here from Dr. Vinod Adbe. Is there esophageal spasm with acid reflux and role of long-acting nitrates?
Can I take that again?
Is there role of esophageal spasm?
You can get severe spasm,
Yes.
and the spasm can be pretty bad. So yes, nitrates, you got to be careful because most nitrates will relax the lower esophageal sphincter as well. If you optimize the acid therapy, many of them will not have chest pain. So it's mainly optimize acid therapy.
Yeah, I think.
But prove reflux in these people before you do anything else.
Right. Yeah, and I think we've also seen in manometry in a lot of our subjects. In fact, we're pulling up our data in the next few days. See all these distal esophageal spasm diagnosis patients and whether they really respond to the PPIs that we give them. Some of them don't ever come back, and I think they don't have probably a true esophageal dysmotility. It's just just reflux causing the motility disturbance. Is that okay?
May I ask Shobna?
Yes, sir.
Is there any statistics of refractory GERD in Indian population? Because whatever has been projected in the Western world, we don't see, at least I don't see that much refractory GERD in my practice. I don't know about the others.
Yeah, so I think Mayank Agarwal has one paper which is recent where he tried to look at patients with who did not respond. And I don't think he found 40%. About 20% of his patients have not responded. So look at his paper and you'll get some data from there.
Okay. And Naresh, what is your experience?
We see, truly refractive GERD in the sense responsive symptom, non-responsive symptoms, or truly refractive GERD?
Truly refractory GERD.
It's there. It is there because we do send these patients for surgery. So we are sending patients for surgery. So those are that refractory group which is close to them.
See, a lot of these so-called refractory GERD will ultimately turn out to be hypersensitive. And a lot of these people do have even a functional heartburn for that matter. And I think we need to be careful before labeling them a totally refractory GERD, because we need to do a full pH impedance and all studies, and then only we label them accordingly. That's my feeling. But I don't think we see refractory GERD so often, but we do see it once in a while. Yes.
Yeah.
All right. Let's see if there's anything else worthy of discussing here. Dr. Tarun is asking, pH metry is normal, GERD symptoms, suspect due to esophageal sensitivity. What are the drugs of choice? Yeah, I think this is relevant as most of us encounter this. What sort of neuromodulating agents do you guys use? Any preference?
No, it depends on whether the patient has anxiety, depression, or both.
Okay.
And whether there is a pain component. So you can accordingly play around. If they have insomnia, you could try clonazepam. If they have just plain, say, depression, could try with sertralines. If they have both, venlafaxine is a good drug. So, you have to play it around depending on what the patient has.
Right.
Don't try only one drug and stick with it.
Additional symptoms, a lot of these patients will have associated constipation. So avoid the drugs which will further worsen.
Yes.
And most of the antidepressants will have some effect.
Yeah. Okay.
Yes. So especially if the patient has a little bloat, it's better not to try escitalopram because that can result in increasing the dyspepsia. So it's just based on multiple symptoms, as Ajay said. We'll take the choice of your neuromodulators accordingly. It's not just one size fits all. It doesn't work that way.
Right. Okay. Dr. Manish Tiwari is asking management of PPI dependent non-erosive reflux disease.
So it's if the patient has reflux, you continue the PPIs, and whenever they have symptoms, I mean, if they stop the PPIs and they have symptoms, go back. And it's very difficult to take off patients with severe reflux of the PPIs. Patients who have mild reflux, you can sometimes do away with the PPIs and tell them, okay, you can do well with on-demand H2 receptor antagonists, or even alginates, or even antacids. So mild reflux can be managed like that, but severe reflux, they do require long-term PPIs. We can't remove the PPIs from there.
I think what he's asking is non-erosive reflux disease.
That's why I think that if it is non-erosive and the symptoms are mild, then we can do this. But we have to prove the reflux in such a case. If the reflux is not proved, there's no point in playing around with the PPIs. Okay.
Perfect.
So that's one.
But Shobna, this NEGM paper has clearly shown the advantage of laparoscopic nascence fundoplication over the medical treatment, and all these patients, they were the non-erosive reflux disease.
Correct. So that is the thing that patients of. So we have to prove the reflux, and that is what that paper from Stuart Speckler has done. That they have actually proved the reflux. They have waited for some time on dual PPIs, and then only it's like saying that the patient should earn his surgery. The patient should say that, look, I need the surgery. Only those will you go ahead and do treatment.
Because surgery is actually less commonly done at our place. Because the PPI are available at low cost, many people, they are afraid of surgery. So surgery is underutilized for GERD.
I agree with you.
Yeah, I think the other issue is this whole labeling of non-erosive reflux disease. I think most patients either try PPI by themselves or have received it, and then the EGD is always going to be negative because that if erosion, if anything was present, is gone by the time the endoscopy is done.
Absolutely. I think I agree with you. And that depends on how long the PPIs were taken. So, like we mentioned earlier in the case, it's very difficult for us to take the PPIs off for 2 or 3 weeks. Even for pH metry, when you ask them to take it off for 7 days, that's also difficult. So if you have to take off the PPIs for at least 50 days, and not only PPIs, you also have to take out the H2RAs and keep the patient only on antacids. Wait for the erosions or whatever to reappear. That's going to be a very difficult task for us. So patients often undergo 1, 2, and 3 endoscopies, all of them normal, and they still continue their treatment despite that.
Right.
Yeah.
All right. I guess most of these are answered along to me. Dr. Praveen Kumar is asking, after long-term PPI therapy, any advantage of tapering the dose and duration before stopping PPI? Do you usually taper it down, Dr. Kumar? Do you slowly taper the PPI down? A lot of practices would do that.
Yes, if I have to, I try all the tricks available to cut down the dose of PPIs, and except for LAC and D, it's a different story. But non-erosive, mild reflux, erosive reflux, esophagitis, I like to try the different tricks. One trick is to half the dose of PPI. You make it, say, pantoprazole 40, make it 20, and so on. Second trick is to make it full dose alternate day. Ultimately, purpose is the same. Thirdly, to make it weekend therapy. I think whatever fits into what particular patient. And so as in between, I do tell them that as and when in between occasional heartburn, they can have an antacid and so on. And as mentioned earlier, that occasionally while you are tapering, you can use alginate to cut down that. So basically, my approach is to cut down the dose of PPIs as much as possible, and then see how they behave. And every patient has to be done according to the patient's status.
Yeah. Okay. So just I think we'll just almost end it here. Just last question. Dr. Vinod Adbe and Dr. GDR are asking you questions related to long-term PPI use. Any evidence to show increase in GI malignancy? One question is gastronoma and diabetes. So any comments on that? And
no,
then we'll stop.
nothing.
Yeah.
No. Okay.
Enough. Okay. All right. So
thank you, everybody.
I think we can.
Thank you very much, Saurabh, and thank you, Dr. Mukkewar.
Thank you.
Yeah, thank you.
I'll hand over to the Alchem team to sort of help with the vote of thanks. But thank you, Dr. Bhatia, and thank you, Dr. Kumar. And Dr. Naresh Bhatt had to leave, so thank you again for being here and sparing your evening time. Thanks.
Okay.
All right. Is the Alchem team around if they want to?
Yes, sir.
Yeah, okay.
Good evening, doctors. As we come to the end of the insightful Refractory GERD webinar, we at Alchem Suprema would like to thank all the participants and the Midas Medical Foundation for making this academic session so memorable. Alchem Suprema sincerely thanks Dr. Philip Katz, the keynote speaker, Dr. Saurabh Mukkewar, who did the brilliant job of moderating the session, and also all the chairpersons, Dr. Naresh Bhatt, Dr. Ajay Kumar, Dr. Srikant Mukkewar, and Dr. Shobna Bhatia for sharing with us their vast knowledge and experience. We also thank all the delegates for being a part of the Refractory GERD webinar despite your busy schedules. And we truly hope you enjoyed the program and had a joyous learning experience. The archives of today's webinar will be available by tomorrow. And to encourage us to do more such programs in the future, we request you for your enhanced prescription support for our new launch, that is PAN 80mg tablets for 24/7 acid control in refractory GERD. So till the time we meet again, we urge you to stay safe and stay healthy and have a nice evening. Thank you, everyone.
Great.
Thank you.
Thank you. Bye.